Good morning, students. I am Dr. Sri Ramya Devi, Assistant Professor from the Department of the Dermatology. I am going to take a class on Hansen's. So, coming to the history of leprosy, by definition, it is a chronic systemic disease caused by Mycobacterium leprae, manifesting as development of specific granulomatous or neurotrophic lesions which involving in the skin, mucous membrane, eyes, nerves, bones, and viscera. And it is the oldest infection known to mankind, and it is also known as Hansen's disease, Kusta Roga. How it is transmitted? The transmission of leprosy by various routes. First is leprosy is spreaded by respiratory route, by inhalation of bacilli-laden droplets. By nasal droplets, it can be spread via the respiratory route. It is the most common cause of transmission, and others like by cutaneous when there is a direct skin-to-skin contact, and via GIT by ingestion of food, and by intradermally inoculation by tattoos. These are the various transmission route for leprosy. Coming to the epidemiological factors, it occurs all age groups. The peak age of onset is between 10 to 20 years. In this, males are more predominant when compared to females, and children are more susceptible. And when there is a low immune status in overcrowding population as well as in low socioeconomic status. And these are the epidemiological factors which aggravating the leprosy. Coming to the prevalence, in this map, you will be seeing blue color, that is dark blue color. It indicates less than 1, and sky blue color indicates up to 1 to 2. Pink color indicates between 2 and 3. Yellow color indicates between 3 to 5. These indicate the state-wise leprosy prevalence rate per 10,000 in India as on March 2005. So coming to the relationship between the immunity and leprosy, in immunity, in the host resistance, which is excellent, means the clinical manifestation shows no infection. When the host resistance is good, there will be subclinical infection with spontaneous regression, which indicates indeterminate, pure, neuritic, and tubercular type of leprosy. When host resistance is fair, clinical manifestation will be mid borderline lepromatous. When host resistance is poor, it is lepromatous, and very pure indicates all the condition. So coming to the Mycobacterium leprae, which is a causative agent for the leprosy, it is an obligate intracellular acid-fast bacillus. It has affinity towards the skin, nerves, and muscle tissue. So only these areas are more commonly affected by leprosy. It is found in macrophages, histiocytes, and Schwann cells, which is present in the nerves. It is not cultivable, so no culture can be done for Mycobacterium leprae for investigations. It is grown in animal models like armadillo. Okay, closely resembles Mycobacterium tuberculosis, but it is less acid fast when compared to the Mycobacterium tuberculosis organism. It multiplies within 2 weeks, around 11 to 13 days. So this is the Mycobacterium leprae organism. So coming to the classification, according to the Ridley-Joplin classification, it is indeterminate, tuberculoid, and borderline. In borderline, again borderline tuberculoid, mid-borderline, borderline lepromatous, and lepromatous. According to the Indian classification, it can be pure neural, maculo-anesthetic also. So, by paucibacillary leprosy, which is present in the following clinical conditions: indeterminate leprosy, tuberculoid leprosy, borderline tuberculoid, and pure neuritic. Multibacillary leprosy, mid-borderline leprosy, borderline lepromatous leprosy, and lepromatous leprosy. asymmetric nerve involvement will be there without any skin lesions, and it can be usually of tuberculoid origin. So coming to the classification of leprosy, the resistance is more commonly seen with the lepromatous leprosy because of the poor host response. Immunity will be very less in lepromatous leprosy when compared to the tuberculoid spectrum, which is on the other hand. So coming to the spectrum, the first will be tuberculoid spectrum, which is the clinical manifestations will show single or few asymmetrical, well-defined erythematous or copper-colored patches, where the sensations are absent and nerves will be thickened, presence of feeding nerves and abscesses can be present. The skin smear shows negative, Leprechaun test shows strongly positive. So course will be relative, benign and stable with good prognosis. So coming to borderline leprosy, common type of leprosy is borderline leprosy, which is further subdivided into borderline tuberculoid, borderline and borderline lepromatous. The course is unstable with variable prognosis, may progress to subpolar lepromatous leprosy. And this common type is most prone for reactions. And leproman test is negative and weakly positive in borderline tuberculoid. We saw strongly positive leproman test in tuberculoid type. Okay, here it is negative and only weakly positive in case of borderline tuberculoid. So coming to the borderline tuberculoid, few asymmetric lesions will be present, which are hypopigmented, skin-colored macules, plaques with ill-defined margins. And there will be a presence of satellite lesions, which is near the advancing margin of the patch. The sensory impairment is marked and nerve involvement is also marked, which are asymmetrical. These features are present in borderline tuberculoid. Remember, as a satellite lesions are present near the advancing margin of patch, marked sensory impairment and marked nerve involvement is present. So here you can see a well-defined erythematous plaque where you can see the nearby small lesions, which are the satellite lesions present near the large lesion. This indicates the borderline tuberculoid, which is present in the posterior trunk as well as in the cheek region. Coming to the mid-borderline leprosy, it is an unstable form and reactions are more frequent. Annular lesions with characteristic punched out appearance shows us an inverted saucer-shaped appearance present in the mid-borderline leprosy. So sensory impairment is moderate, nerve involvement is marked and asymmetrical. So coming to borderline lepromatous leprosy, there are multiple shiny macules, papules, nodules and plaques with sloping edges are present. So there will be shiny macules will be present. In case of borderline lepromatous leprosy, it can be macule, papule, nodular plaques with the sloping edges. Where we previously saw in mid-borderline lepromatous leprosy, there will be inverted saucer-shaped lesions will be present, like annular lesions, which are appear as a inverted saucer-shaped appearance. In borderline lepromatous, you see here multiple shiny macules, papules, nodules, and plaques with sloping edges are present. Here, sensory impairment is slight and nerve involvement more widespread and less asymmetrical, whereas the previous borderline types are more symmetrical when compared asymmetrical when compared to the borderline lepromatous leprosy. Here you can see have a glove and stocking type of hypothesia involving acral parts of the body. Here you can see the multiple hypopigmented macules and also patches involving the posterior trunk and the upper arms, and in the right shoulder you can see a xerotic patch involving the right shoulder where you can see the dryness of the skin present over the patch because of the loss of sweating and hair follicles. This clearly indicate a leprosy patient. So coming to the lepromatous leprosy, we saw hypopigmented erythematous or coppery shiny macules, papules, and nodules. Lesions are symmetrically distributed, small, multiple, shiny with normal or mild sensory loss, and there will be a leonine phases. Here, the lesions are more infiltrated of skin with nodules, loss of eyebrows and eyelashes, which is known as a madarosis. So nerve involvements are symmetrical, glove and stocking anesthesia will be present, Leperman test is negative. So in this patient, you see a multiple erythematous nodules infiltrated over the face, which is indicate of lepromatous leprosy type. So this is a picture of showing leonine phases. Here you can see the multiple infiltrated nodules present over the forehead around the perioral region and periorbital region. This shows a leonine phases, and there also a madarosis is also present. You can see the lateral third of the eyebrows are lost. So it indicates madarosis. When there is a madarosis and infiltration of the skin with nodules means it indicates lepromatous leprosy, and this is a feature of leonine phases which can also be present in some other dermatological conditions like mycosis fungoides. So coming to the indeterminate leprosy, it is asymmetrical, single or multiple hypopigmented or faintly erythematous and ill-defined macules, sensation or normal or slightly impaired, peripheral nerves are normal, skin smears negative, Leperman tests are unpredictable and variable, and course is usually it is self-limiting and may progress to other forms of leprosy. So here sensation peripheral nerves are nearly normal, skin smear is negative, and whereas Leperman test is unpredictable and the course will be self-limiting and can go to any form of leprosy. So in this child, you can see we have hypopigmented macule present over the left side cheek, and we can misunderstand as a pityriasis alba or versicolor. So you should do a thorough clinical examination and proper history along with positive family history you should take to rule out Hansen so that you can cure the patient. So coming to the pure neuritic leprosy, there will be a neuritic manifestations like tingling, heaviness and numbness, paresis, hypotonia, atrophy, claw hand and toes, wrist drop and foot drop. And there is no skin lesions. Other changes like anhydrotic, dry glossy skin, blisters, neuropathic ulcers, decalcification and bone resorption. These are the other changes you can observe in pure nephritic leprosy. I again repeat, there will be only neuritic manifestations, mainly no skin lesions. So neuritic manifestations like tingling, heaviness and numbness, paralysis means weakness of muscles, hypotonia, reduced movements, toning of a muscle, atrophy, claw hand and toes, wrist drop, foot drop or other deformities will be present, and there is no skin lesion and other changes like anhydrotic. Anhydrotic means there is loss of sweating in the skin. You saw a xerotic patch, that is dryness of skin in the patch which is present in the previous picture which is shown. So there will be dry glossy skin, blisters, neuropathic ulcers, decalcification and bone resorption. Why there is a neuropathic ulcers? Because of there is a numbness, loss of sensation. When they hit, they doesn't know the pain. So when they leave it, it turns into ulcer. So you should tell the patient to check every day before going bed to check their hands and foot if they are having any trauma. Coming to the other special forms of leprosy, First is leprosy. It is a rare form of lepromatous leprosy which is described in Mexico. There is diffuse, widespread infiltration of skin, loss of body hair, loss of eyebrows and eyelashes, which I told these are the features of madarosis, and widespread sensory loss. So, leprosy is other than a rare form of lepromatous leprosy. So, coming to the pretty leprosy, lepra bonita, because in elderly patients with diffuse infiltration of face smoothes out the wrinkles. So when the wrinkles are smoothed out, it gives a youthful appearance. So only this type of leprosy is known as the pretty leprosy, lepra bonita. So coming to the histoid leprosy, in borderline lepromatous patients with irregular or poor treatment compliance and due to the drug resistant cases, there will be histoid leprosy. So, eye involvement in leprosy, mainly lag of thymus, which can be partial or complete. It can be unilateral, that is, one side or both eyes can be involved bilaterally. Coming to other features of eye involvement like conjunctivitis, exposure keratitis, and corneal ulcers, madarosis, trichiasis, which leading to corneal vascularity and opacity. Dacrocystitis can be acute, subacute, or chronic. Nodules on sclera, episcleritis, and scleritis. Corneal nodules and lepromatous pearls can be present. Microlepramata, nodules on iris and ciliary body also present. And these are the features of eye when there is involvement of eye during in leprosy patients. Coming to the nerve involvement in leprosy, sensory involvement shows anesthesia in hands and feet, glove and stocking anesthesia, mainly we saw in lepromatous type and due to repeated trauma. Motor involvement, there will be wasting and paralysis of the muscles. So it affect the motor involvement and autonomic involvement like ichthyosis means dryness of skin, loss of hair like madarosis and sweating is lost. So because of sweating is and the hair loss is there, there will be dryness of the skin. So other features like due to crusting, there will be nasal stuffiness. When the patient removes the stuffiness, it can result in epistaxis and because of stuffiness also it can cause epistaxis, hoarseness of voice, gynecomastia in male patients and saddle nose deformity, bone resorption and lymphadenopathy is present. These are the other features in leprosy patients. What are the differential diagnoses of leprosy? In case of macular lesions, when there is a depigmented patch, you can think of vitiligo and other occupational leukoderma and fungal infection like tinea versicolor, pityriasis alba, post-calozadermal leishmaniasis, nevus depigmentosus, and scars. So coming to infiltrated lesion, what are the differential diagnoses to these type of lesions like lupus vulgaris, lupus erythematosus, granuloma annular, annular syphilis in case of syphilis, post-Kala-Azar dermal leishmaniasis in infiltrated lesions, sarcoidosis, and psoriasis. So, differential diagnosis for nodular lesions in leprosy patients, you can think of post-Kala-Azar dermal leishmaniasis, cutaneous leishmaniasis, syphilis, onchocerciasis, sarcoidosis, leukemia cutis, mycosis fungoides, and nodules of neurofibromatosis. So, in neurofibromatosis, you can see the multiple nodules studded over the skin. So, it is one of the differential diagnosis of leprosy when there is a nodular lesions are present. So coming to the sensory impairment with or without muscle wasting, differential diagnosis like peripheral neuropathy, diabetic neuropathy, primary amyloidosis of peripheral nerves, congenital sensory neuropathy, syringomyelia, tabes dorsalis, thoracic outlet syndrome, and alcoholic neuropathy. These are the Differential diagnosis in case of sensory impairment with or without muscle wasting. So coming to the diagnosis, based on the cardinal signs of leprosy. These are the three cardinal signs you should remember, which is most important to rule out leprosy. First will be sensory impairment in the affected areas. Second is enlargement of peripheral nerves associated with signs of peripheral nerve damage and finding of acid-fast bacilli in the lesions. So I repeat, because this is most important three cardinal signs of leprosy. First will be sensory impairment in affected areas, enlargement of peripheral nerves associated with signs of peripheral nerve damage, finding acid-fast bacilli in the lesions. So, clinical examination. First, you should check for skin lesions, the type and number of skin lesions, whether there is any sensory impairment in those lesions, and motor examination, nerve examination, sweating, and loss of hair. By sensory, you should rule out the three sensations like touch, tested with the wisp of cotton, which is a light touch, while or nylon thread or feather. To rule out touch, temperature by two test tubes, one containing hot water and other one is cold. So by using these two test tubes, we can examine the temperature. Third one is pain, which is tested by the pinprick. So sensation, what are the sensation? You will do clinical examination means touch, temperature and pain. So what are the motor clinical examination means? Testing the motor power, which is done clinically. And the electrode diagnosis employed in very early cases, electrical stimulator using Faradic and galvanic current used to test muscle power. So coming to the nerve examination, what are the nerves you can examine clinically? Like whether the lepra is infiltrated, whether the nerve is thick, infiltrated by rolling over the nerves with the help of the fingers. You can suggest whether the nerve is involved or not, or whether it is painful or unilateral or asymmetrically involved. So what are the nerves you should examine clinically or supra or infraorbital nerve, greater auricular nerve, clavicular nerve, radial nerve, superior radial cut, and cutaneous, superior radial cutaneous nerve, ulnar nerve, median nerve, lateral popliteal, posterior tibial nerve, anterior tibial nerve, and sural nerve. By the sural nerve, nowadays they are taking biopsy also to rule out the leprosy. So these are the nerves we can examine clinically. What are the investigations of our Mycobacterium leprae? By bacteriological examination, first skin smears. The slit skin smear test is there. So made by slit and scrape method from the most active looking edge of skin lesions and stained with Ziel-Nielsen method. The reading of smears has two index. One is bacteriological index, another one is morphological index. In bacteriological index, you can measure both live and the dead bacilli, which indicates the density of the leprosy bacilli in the smears, which ranges from 0 to 6 plus. Morphological index, it is a percentage of presumably living bacilli in relation to total number of bacilli in the smear. So coming to the other investigation, histopathological examination, where you can see the granulomatous reaction in case of lepromatous leprosy, more number of eosinophils and neutrophils are present. Others like nerve biopsy, which I told, sural nerve can be, a small part of sural nerve can be taken for the nerve biopsy to rule out leprosy, sweat function test, lepramin test, and animal models, which I told previously, it is non-cultivable. While Mycobacterium leprae organism is non-cultivable, so we can use animal models like armadillo, thymectomized, irradiated mute mice, Korean chipmunk, etc. So what are the other newer investigations help to rule out Hansen's like serological assays like FLA, ABS, RIA, ELISA, phosphoglycolipid polymerase chain reaction, and other techniques like chemical, immunological, molecular, biological, bioluminescent techniques, strain-specific probes. Indications to confirm diagnosis in complaining of inconclusive histopathological or smear reports. These are the indications for the other investigations, like to distinguish between reaction and relapse, to demonstrate Mycobacterium leprae or its components, to elicit strain differentiation for molecular epidemiology, to detect drug susceptibility or resistance. In this picture, you can see the lepromatous leprosy showing the granulomatous reactions with multiple eosinophils, neutrophils are present. Coming to the WHO regimen, treatment of the Hansens for paucibacillary, the duration of time is 6 months. Only 2 drugs like capsule rifampicin 600 mg monthly once dose under supervision and tablet tabs on 100 mg daily should be given in paucibacillary for the duration of 6 months. In case of multibacillary leprosy, duration will be 1 year. Capsule rifampicin 600 mg and capsule clofazimine 300 mg given monthly. That means monthly once under the supervision they should take the tablet, and tablet dapsone 100 mg and capsule clofazimine 50 mg should be taken daily for the period of 1 month in multibacillary leprosy patients. Blister packets for MDT, which are easy to use, handy, and of convenient size, provide complete treatment, improve clinical attendance. Drugs are better protected against moisture, heat, and accidental damage, ensures quicker dispensing of the drugs, and can be dispensed by non-medical person. So these are the blister packets. In case of adult, multibacillary leprosy shows the pink color blister packet which contains rifampicin 600 mg and clofazimine 300 mg once monthly, dapsone 100 mg, clofazimine 50 mg daily up till completion of 12 monthly pulses. In case of paucibacillary leprosy, rifampicin 600 mg once monthly, dapsone 100 mg daily. These are completion of 6 monthly pulses. In case of children from 10 to 14 years of age, the blister pack is yellow color for multibacillary leprosy, which contains rifampicin 450 mg once monthly, clofazimine 150 mg monthly, and dapsone 50 mg and clofazimine 50 mg. Dapsone 50 mg will be daily dose and clofazimine 50 mg is alternate days till the 12 months duration. Paucibacillary leprosy, rifampicin contains 450 mg once monthly and dapsone 50 mg daily, completion of 6 monthly pulses. When the children less than 10 years, according to the body weight, we can give the drugs. So coming to rifampicin, 10 mg per kg we can give, and clofazimine 6 mg per kg monthly and 1 mg per kg per body weight daily can be given. Dapsone is 2 mg per kg body weight daily. So these are the blister packets which are given in leprosy. Pink color, that is A picture, pink color is the blister packet for multibacillary in adults, and green color C picture shows green color blister packet for the paucibacillary in adult. Yellow color B picture which shows a yellow color blister packet for multibacillary in children, and D which shows a blue color blister packet for paucibacillary in children. So what are the other regimens other than MDT? Like ROM regimen. ROM is nothing but it comprises of rifampicin 600 mg, ofloxacin 400 mg, minocycline 100 mg. Single dose for single patch, which is WHO accepted one. ROM for 6 months, monthly for 6 months, paucibacillary. ROM 12, monthly for 12 months for multibacillary. Newer drugs or regimens like rifampicin and ofloxacin 28, fluoroquinolones nalgesic acid, macrolides like clarithromycin can be given, ansamycin like rifabutin and rifampicin, dihydrofolate reductase inhibitors, brodimoprin, K130. Other than that, fusidic acid, beta-lactam antibiotics, cephalosporins. If there is any added superadded bacterial infection, quinolones, bifloxacin, and sparfloxacin also can be tried. In case of immunomodulated drugs like levamisole and zinc can be given. Antigenically related mycobacteria like vaccines can be leprosy vaccines can be tried like BCG vaccine, Mycobacterium leprae, along with BCG vaccine, Mycobacterium Welsh vaccine, and ICRC vaccines. Other immunomodulators like gamma interferons, interleukins. Coming to the lepra reactions, acute episodes are bouts of exacerbations occurring in course of chronic disease, sudden increase in activity of existing lesions, appearance of fresh lesions with or without constitutional symptoms. Coming to type 1 reaction, it involves all borderline cases will go to type 1 reaction like borderline tuberculosis, borderline lepromatous. Coming to type 2 reaction, only borderline lepromatous and lepromatous leprosy cases will occur type 2 reaction. What are the precipitating factors for reaction? When there's a physiological condition like pregnancy, drugs like anti-leprosy drugs, iodine, severe physical or mental stress, and other infections. Coming to type 1 reaction, subtypes like upgrading, that is reversal, downgrading. Type 4 sensitivity reaction is type 1. Existing lesions are worsened or newer lesions may appear. Neuritic or nerve abscesses will be present. Systemic disturbances are unusual. And what are the complications in type 1 reactions are neuritis, dactylitis, that is edema of the hands and feet, inflammation of small joints and fingers, corneal anesthesia and conjunctivitis, sudden occurrence of claw hand, foot drop, and facial palsy. Coming to type 2 reaction, which occurs in BL and LL cases, in type 3 hypersensitivity reaction. But type 4 hypersensitivity for type 1 reaction. In type 2, there will be a type 3 hypersensitivity reaction, erythema nodosum leprosum, frogs of painful recurrent erythematous papillonodular lesions are present, and constitutional symptoms like fever and malaise are present, and hydrocyclitis, episcleritis, epidermolysis, arthritis, neuritis, and elephantitis. What are the complications in type 2 reactions? Frozen hand, laryngitis, non-paralytic deformity, polyarthritis or rheumatoid arthritis like syndrome, multiple dactylitis, leukocytosis, anemia, raised ESR, albuminuria or nephrotic syndrome, liver or spleen enlargement, epididymitis or architis, testicular atrophy or sterility, gynecomastia, adrenal gland hyperfunction, and eye involvement. Treatment of lepra reactions by principles of treatment like early initiation of treatment for reaction, continuation or initiation of MDT therapy, and removal of a precipitating factor, rest for both physical and mentally. Coming to the treatment modalities for reactions when there is no pain, analgesics, steroids, antimalarials like hydroxychloroquine, clofazimine, thalidomide, miscellaneous drugs like colchicine, zinc, cetirizine, antimonial, supportive management for eye complications, splints, etc. So deformities in leprosy in primary are caused by the tissue reaction to infection with M. leprae, example leonine phases, flat nose and claw hand. Secondary occur as a result of damage to the anesthetic parts of the body, example plantar ulcers and corneal ulcers. So grading of deformities or disabilities, WHO classification, at grade 0, there will be no anesthesia, no visible deformity or damage in hands and feet, or no problems in eye or no visual loss. Grade 1, anesthesia present, but no visible deformity or damage, eye problems present, but vision will be 6 by 60 or better. Grade 2, visible deformity or damage present in hands or feet, and vision worse than 6 by 60. Primary deformities like previously discussed like leonine faces, loss of eyebrows and eyelashes, madarosis, depressed nose, saddle nose deformity, gynecomastia, and palatal perforation. Secondary deformities like corneal ulcers, opacities, plantar ulcers, palmar ulcers, and ulcers in the fingertips, disruption and charcoal joints. So nerve damage due to deformities like claw hand, ulnar and median nerve can be partial or complete. Total claw hand will be present. Clawing of the toes because of involvement of the posterior nerve. Wrist drop due to radial involvement. Foot drop due to lateral popliteal nerve involvement. When there is a facial nerve involvement, lag of thalamus and facial palsy can be present. So this is the complete claw hand which is present in both the hands. You can see the flexion deformity in the IP joints, and they are enabled to extend the fingers. So coming to trophic ulcer stages, threatened ulcer, concealed ulcer, and open ulcer. These are the three stages. Threatened ulcer shows slight puffiness and warmth in region of metatarsal head with associated tenderness. Concealed ulcer shows necrosis, blisters at the site of damage. Open ulceration like frank ulcer. Types of ulcers like acute ulcer, chronic and complicated ulcer. So coming to the prevention of deformities, early detection of nerve damage, adequate treatment of leprosy patient, use of protective footwear, adequate hydration of the skin, and physiotherapy. Management of deformities, education of patient regarding prevention of injuries, daily examination of hands and feet, and prompt treatment for minor injuries using adapted tools and appliances after training, reconstructive surgeries, and rehabilitation methods. Coming to physiotherapy, can be oil massage or wax therapy can be used. What to make the skin? What are the uses by this physiotherapy? Or to make the skin soft and supple and loosen stiff joints. As a preliminary to exercises to strengthen muscles and keep joint mobile. To reduce pain in acute neuritis. To stimulate innervated sweat glands to increase blood flow. So the splints which can be used in physiotherapy like indication, acute neuritis, mobile deformities to prevent uh, fixed deformities to correct the other deformities. Splints used for radial neuritis like static or dynamic wrist drop splint, for mobile deformity static or dynamic splint, for fixed deformity, cutter, cutter splints and finger loops, etc. Electric stimulation like to maintain the tone of denervated muscle, helpful in breaking post-operative adhesions after tendon surgery, could be used as a means of documenting nerve damage and the progress of the nerve recovery with treatment. Prevention and control of leprosy. First, prevention of leprosy by early detection through survey and initiation of treatment. Families of patients to be kept under surveillance. Immunoprophylaxis using leprosy vaccines, BCG vaccine, M tuberculosis Welsh can be used. ICIC vaccines can be used. Improvement in socioeconomic conditions and control of leprosy by three activities. One is case detection, case holding for including the treatment and health education of public and patients. Leprosy organizations like UNICEF Lepra, Danida, SIDA, Leprosy Mission, American Leprosy Mission, German Leprosy Relief Association. Leprosy control programs like National Leprosy Control Program 1954, Triad of Survey Education Treatment, that is said National Leprosy Eradication Program 1982. National Leprosy Eradication Program eradicate leprosy from the country by 2000. Vertical health program in areas where prevalence of leprosy is more than 5 per thousand. Horizontal program in areas where the prevalence rate is less than 5 per thousand. In NLEP, that is National Leprosy Eradication Program, three main units for program operation: basic tier survey, education and treatment unit, leprosy control unit, and urban leprosy control unit. Second tier is a district or zonal leprosy office. Third tier like leprosy division of the state directorate of the health services. Coming to the rehabilitation in leprosy, physical and mental restoration of the patients to normal activities so that they are able to assume their place in the home, society, and industry. Treatment of physical disability, education of patient, family, and public, rehabilitation in special homes or institutional rehabilitation, community-based rehabilitation. Thank you.